So welcome to this PCFA educational webinar on prostate cancer and active surveillance, looking at quality of life following a diagnosis. So my name is Chris and I'll be hosting today's webinar, bringing together a couple of experts in the prostate cancer space to discuss active surveillance for prostate cancer. I'm honoured to be joined today by Professor Declan Murphy, who, as most of you know, is a real pioneer and an expert in all things prostate cancer. Declan's a consultant urologist and director of genitourinary oncology and the director of robotic surgery at Peter McCallum Centre in Melbourne. And he's the professorial fellow at the Sir Peter McCallum Department of Oncology at the University of Melbourne. He's previously been consultant urologist at Guy's and St Thomas's NHS Trust in London. And Declan specialises in full-time in GU oncology and prostate cancer in particular. And is in private practice based at the Cancer Specialists in Melbourne. And on the side, Declan's also a host of the GU podcast and is a main conference video engagement specialist. So thanks for providing your time today for this webinar, Declan.
Thanks, pleasure, Chris.
So joining Declan today is to discuss the impact of active surveillance on a man and his family is Ian Henderson. And Ian's a PCFA prostate cancer specialist nurse at the Royal Hobart Hospital in Tasmania. Ian's also a pioneer as one of the first prostate cancer specialist nurses in Australia way back in 2012. And Ian's nursing career has been wide and varied and includes rural, remote, Indigenous nursing in the Northern Territory, critical care nursing in rural Victoria, and most recently, for a few years now, is the prostate cancer specialist nurse in Hobart at Royal Hobart Hospital. So some really great vocational experience you've had there to lead to this specialist role, Ian. So thank you very much for giving us your time here today.
Thanks, Chris.
So thank you to everyone for tuning in today. We'll start with a presentation about active surveillance by Professor Murphy, and we'll finish the webinar with a Q&A session at the end. So if you've got any questions throughout the webinar, please pop them into the Q&A box at the bottom of the screen, and we'll endeavour to answer them during today's session. So let's get things kicking off, and I'll hand over to you, Declan.
Terrific. Well, thanks, Chris. Thanks, Ian, and thanks all of you for tuning in. I'm sure a lot of you are also watching the cricket, by the way, in the background. That's okay. That still counts, you know. I may actually have an iPad in front of me watching the occasional wicket or runs, actually, as well. So another really important topic today, one of the most important topics, I think, for any of us working in prostate cancer, the topic of active surveillance. And although we've been doing surveillance for quite a few years, there are still lots of reasons why we should talk about it more often, and we should update ourselves as a multidisciplinary community for how we maximize the utilization of surveillance, make sure it's safe, and make sure that overall we can get the balance right between making sure patients only need treatment and side effects if they really need it, and in other words, can have their cancer very safely observed if at all possible. So I'm going to run through just a few thoughts, a few background points on active surveillance to get us going, but we're really looking forward to engaging with you. So as Chris said, please pop your questions into the Q&A and upvote them, the ones you really want us to talk about. And I look forward to hearing from you and educating myself on your own perspectives dealing with patients in this setting. So let me share my screen with you, and let's talk a bit about active surveillance. So what I'm going to talk about first is a bit about surveillance, kind of presuming maybe some of you aren't that familiar with it, just the background, why we do it and how we do it, plus some concerns I have about the way we're doing it today. And then finally, just a short bit to finish on, the fact that these patients have localized cancer, and often they're weighing up decisions about treatment versus surveillance as well. And let's remind ourselves at the very start a little bit about staging and grading of prostate cancer, because that really underpins how we select patients for surveillance. These figures here are taken from the Cancer Council Understanding Prostate Cancer leaflet. Yes, I'm at home. The dog has just started barking. So excuse me, he'll stop in a moment. And what you'll notice is that we tend to stage prostate cancer based on whether it's localized, confined to the prostate, or advanced. And the vast majority of cases are, of course, localized. And then within localized, that's this whole box here, we stratify into low risk, intermediate risk, and high risk. And that risk being all about the risk of progression or recurrence in the future. And these for us, I suppose, are the sweet spots. This is where we want to identify men who perhaps don't need active intervention. So the risk is based on not just the PSA level or the biopsy or the rectal examination / MRI, but a combination of these things. So when we have a newly diagnosed patient, these are the things we're looking at, and then we're going to slot them into one of these boxes: low risk, intermediate risk, or high risk if it's confined to the prostate. And so these are the sort of factors we're looking at. What's the PSA level? What's the grade group or Gleason score, as we talked about in the old days? And how does it feel on examination? And as you go up here into the higher risk groups, you can see the PSA is going a bit higher. They tend to have higher grade cancers. And in the high risk group, you have to have one of these findings. So you don't need all of these, to be in intermediate or high risk. But certainly the ones down the left here are the ones that are most suitable for active surveillance. And it's really important to get this right at the start. So when we write summary letters, we usually very clearly define the PSA level, the grade group, and the rectal examination plus MRI findings, so that we can clearly say this is a low risk patient or favorable intermediate risk, and so on. And this is a really useful document. And of course, our friends at Movember support a lot of the really valuable stuff that we do looking after our patients, including supporting a lot of the research that PCFA have overseen in the past 10 or 15 years in Australia. And in the past few years, they've also supported PCOR, the Prostate Cancer Outcomes Registry, which we've been very involved with. PCOR started off with the Victorian Registry and has now expanded across Australia and New Zealand. And every year, Movember produce a fantastic report about prostate cancer in Australia and New Zealand based on this data. So this is some of the data from the 2020 report. And I find this really useful when people ask me questions like, well, what's the proportion of patients that are localized at diagnosis or low risk and so on? What proportion of patients have a transperineal biopsy versus a transrectal? How many patients have surgery versus this, that? Because it's quite contemporary and now spans the whole country. So it's a really, really useful document. If you just Google Movember PCOR report, you'll find yourself there with the annual report. So this is what it currently tells us about the state of play across Australia to answer that question about what's the stage of cancer when men are diagnosed. And what you see here is that 89% are localized. That's what these numbers here mean. 27% plus 44, blah blah blah. And only these top 10 or 11% are either metastatic at diagnosis, 7%, or locally advanced into lymph nodes and so on. And down here at the bottom is therefore the proportion of patients with low risk prostate cancer at diagnosis across all the men diagnosed. So about 1 in 5, about 20% are low risk at diagnosis. Of course, that's a bit higher if you exclude the metastatic patients. And if you exclude the high risk patients, the ones who tend to always need some treatment, you can see this proportion is maybe up to 1 in 3 of newly diagnosed localized men who may be suitable for surveillance. So a really important, substantial group of patients. There's a question, of course, what about this box? This is the biggest, the most common group of patients, those with intermediate risk prostate cancer. Is there a proportion of them that can be managed with surveillance? Yeah, there is, and I'll show you that in a second. So what I'll show you first of all is the patterns of care for the low risk men, and this is over the subsequent years. So the 2020 report had comprehensive data up to 2018. And what you see here in gray is the increasing proportion of patients who are being offered active surveillance as the primary management option across all populations in Australia. So this is not just academic or not just public or private or whatever, it's across all comers. And look at it, it's really encouraging to see, even within a relatively short period, the increasing utilization. So about 71%. We'd like to see it even higher. And people will say, well, what is the right number? Real enthusiasts will say it should be like 90%. I think probably around 80% is probably a good number, because there will always be a proportion of low risk patients, like, for example, a 50-year-old with a PSA of 9, with all cores involved with grade group 1 prostate cancer, whose father died in his 50s of prostate cancer, and 2 uncles now have metastases in their 70s. And that patient will just be someone whose risk is different to a patient who's 68 with 1 core of grade group 1 cancer with no other history. because they're both low risk, but the comfort that the patient and clinician will have for offering surveillance will be different between them, even though they all appear in this box. But I think, yeah, probably about 80% is a good number. And certainly by international standards, these are good numbers for sure. What about the intermediate risk? This is the biggest group of patients by category. And you can see that, this is increasing a little bit as well. Up to 14% of newly diagnosed intermediate risk prostate cancer patients are being managed with surveillance. So these are the more favorable intermediate risk, because it's quite a heterogeneous group based on biopsy findings and age and so on. But it's good that we're already selecting a group of patients. But I think in the next 10 or 15 years, this is probably the big opportunity area. Can we increase the use of active surveillance by better tools to safely identify those patients? And I'll explain what I mean by safely in a moment, because the whole principle of surveillance is that we avoid intervention and the side effects of intervention without compromising, of course, the likelihood that a patient is going to progress and have a bad outcome, because we selected the patient incorrectly, and lo and behold, they get metastatic while we're not looking. So the whole point is presuming that we can safely offer surveillance such that if patient's cancer changes, we identify it in plenty of time, and they're not going to have a missed opportunity. And hence, as you push into intermediate risk cancer, of course, the risk is going higher. So we have to be very careful about, not disadvantaging the patients by being too keen on surveillance. So the data is very good for low-risk disease. Lots and lots of famous series, a lot of it led by Laurie Klotz in Canada. This is his very long follow-up paper from 8 or 9 years ago, showing, look, this really, really good long-term cancer-specific survival. But look, of the few patients who did get metastatic disease, the vast majority of them were patients with intermediate risk features, pattern 4 cancer. So I'll summarize that here in Australia, active surveillance is very widely accepted for low-risk cancer, and the utilization continues to increase. So maybe we'll be up at 80% already actually in 2020 by the time we see that full data in a couple of years' time. And the long-term safety data for low risk is very good. And an overarching message here is that the use of surveillance has mitigated the so-called harms of widespread PSA testing leading to overdiagnosis. So we try and say back to the critics of early detection and use of PSA, look, we no longer treat those men with low risk cancer, but what the widespread use of PSA testing means is we find those men who will benefit from intervention due to their high intermediate risk or high risk cancer. And this is just a patient selection example. This is easy, 68-year-old, very low risk. Very low risk, by the way, means low risk, but only 1 or 2 cores involved versus, many cores involved. Relatively low PSA. PSA density is favorable. That's the ratio of PSA to volume. No family history of concern, a totally normal looking MRI, and a biopsy just showing a couple of cores. So that's easy. No one's going to treat that. The more difficult ones, as I mentioned, are the younger patient with a higher PSA, with an abnormal MRI, with maybe 7 or 8 cores involved, and maybe up to 12 or 15 millimeter length. That's still low risk, but we have to watch those patients a little bit more carefully. And certainly, once you get into Gleason 3+4 or grade group 2, as we call it, you have to be very careful about how you select patients. So they tend to be older patients, and you have to be careful with your counseling. So how do we do surveillance? Well, there's lots of protocols. We've written lots about this over the years. This is just piles and piles of protocols about how we select patients. So it's PSA. Some protocols use PSA density. What's the clinical stage on finger examination? What's the Gleason score in the old days, grade group 1 as we call it, and relatively low number of cores. So in other words, there's quite a lot of variety. And we tend to be quite generous in how we select patients. Certainly, we don't restrict number of cores, for example, because nowadays with transperineal biopsy, that often means more cores than some of these traditional series like the Royal Marsden or the Canadian series. So by and large, it's a mixture to get a feel for what's safe. And then how do we define what progression means, or reclassification, as we like to call it? Well, changes in PSA or changes in the clinical stage can be used, but generally speaking, for us, it's nearly always changes in the grade of the cancer on that repeat biopsy. So certainly changing up to grade group 2 cancer or grade group 3 cancer for us would mean, yeah, no longer, this cancer has changed from grade 1 to grade 2 or grade 3, and that would be a strong trigger for a change in management away from surveillance towards intervention. And how do we identify those changes? Well, I tend to do a PSA test every 6 months or so. I rarely do a DRE, I must say, unless there's been a significant change in other factors like MRI. And a confirmatory biopsy is still really, really important. So note that all protocols will mandate some sort of biopsy, repeat biopsy built in to the follow-up. And in our practice, we tend to do it between 12 and 18 months. That's my typical window. 12 months if it's a slightly, higher volume cancer at the start in a younger patients, 18 or up to 24 months really, if it's a less risky looking situation in an older patient. Now, the traditional data hasn't used MRI in routine protocols, but nowadays, of course, it's all built in to protocols, and we'll talk about that in a second. But by and large, in summary, almost all the protocols tend to restrict to grade group 1 low risk prostate cancer. And all protocols list the change in grade of cancer and increasing numbers of biopsies as triggers for intervention. But we all tend to extrapolate a little bit out of these protocols in favor of trying to maximize the use of surveillance. So what about MRI? Well, of course, in Australia, we have a widespread use of MRI for many years now, and it's been reimbursed for 3 years. So there's no excuse for not using it. So we're very keen on using it because we have easy access to our patients, and all over Australia, we have very high quality MRI. And we use it to avoid biopsy. So we'll always accept that a biopsy will be more accurate than an MRI. But if you don't have any red flags or concerns about a patient, I think it's reasonable that we are using MRI, perhaps to defer that second or third biopsy, especially once you've had 2 biopsies already. You've been on surveillance for 3-4 years, no red flags, you're now 72. If the MRI is normal and the PSA is staying the same, we'll often see, can we defer out that biopsy or avoid it altogether? But I'll warn that the data is a bit lacking. So we have to be careful and say to our patients, MRI will miss small significant cancers in a proportion of patients. And biopsy is the other thing that's really important for making sure that we safely identify patients for surveillance. And as you probably know, in Australia, we have really wide utilization of transperineal biopsy. And the Movember report tells us that across Australia now, more than 50% of all prostate biopsies in all settings, public, private, regional, metro, overall, more than 50% of all prostate biopsies are transperineal. So there's been great uptake compared to every other country in the world. In the UK, it's still much lower than that, although some centers are very high volume transperineal. And likewise, in some centers, enthusiastic centers, that have been using it for a long time, like us at Peter McCallum, we totally stopped transrectal biopsy more than 10 years ago. We've obviously got 100% utilization. But this is a good thing, let me tell you. I think for safety and for accuracy reasons, we're keen on this. And certainly for active surveillance, I think this is one of the things we've learned is that, having the combination of an MRI and a transperineal biopsy at the start means you're more likely to better select your patients. You're less likely to miss an anterior cancer that you might miss on a transrectal biopsy. So I think in Australia, we have very high and increasing standards of selection of patients and monitoring of patients because of increasing access to transperineal biopsy, which, by the way, in the MBS item number review last year, it led to an increase in the reimbursement for transperineal biopsy, largely driven by the patients on the advisory board saying, we should be making sure as many men as possible avoid a transrectal biopsy. And everyone said, well, it's more expensive to do transperineal. So the government, increased the rates of reimbursement so that hopefully more hospitals can afford to offer a transperineal biopsy. And it's very safe. I won't show you that, but, we think it's important if you're going to be on active surveillance, certainly that you have a transperineal biopsy. If you didn't have it at the start, it's certainly good to do it within a year or so, just to make sure you've well selected your patient. And I've mentioned that we have. So second messages for you are that we have good protocols out there all the way around the world, including from Australia, that give us great guidance to say, here's a safe pathway for active surveillance. And there are nuances for which type of pathway you want to use, but I think I've given you by and large some of the rough ideas. PSA every 6 months, repeat MRI and biopsy between 12 and 18 months, and then every 2 to 3 years thereafter. But there are a few concerns about active surveillance that I want to share with you. And one of them is this, that we published this paper in the MJA a couple of years ago, where we showed that really we weren't doing active surveillance that well. Here's the paper. And we looked at 1,600 men on surveillance from the Victorian Prostate Cancer Registry. And we wanted to see how well we were doing surveillance across the registry. So in other words, again, all sectors, public, private, metro, regional. And we defined adequate surveillance with a very loose definition of, say having had 3 PSAs over a 2-year period, and at least 1 additional biopsy within the 2 years. So that's the question. If we were in a room together, I'd ask you that question. What proportion of patients on active surveillance do you think would be meeting this kind of minimum threshold of adequate surveillance? And disappointingly, 3/4 of men in the registry did not meet this relatively low bar. And it wasn't just that they didn't get the biopsy, it was also some of them didn't even come back for PSA testing. And, we showed that it was a bit worse in the public sector than in the private sector. And we have separately developed a different project, a qualitative project, to go out and ask men and clinicians about the reasons why this might be. Is it that patients just don't want to come back, or patients weren't correctly informed? They thought they were all clear and didn't need to come back, and so on. But I'd ask you as key stakeholders in looking after these men just to be aware of this. I'm sure it's the same all over the country. If it's like this in Victoria, there may be some people slipping through the hoops, and this is before COVID. So be aware that if we have men on surveillance, there are protocols to guide even a low bar for what might be safe surveillance. And we must do our best to make sure that these men at least meet that minimum threshold, so we don't have progression due to inadequate surveillance. So yeah, that's another message for you, is that adherence to protocols is low, very low, I would say. And patients and clinicians need to be aware and vigilant, because I think there are failings in both the patient side and the clinician side for why that might be. And maybe we need to actually work out how to do active surveillance better by sharing care, especially out of hospitals, I think, into nurse-led and GP-led care models, just to make sure that there are triggers to make sure they're getting this done, and that they come back in for a biopsy when necessary. Maybe we can talk about that a bit later, Chris. So then a final short section just talking about aspects about decision-making in active management versus active surveillance. Because of course, this sort of patient we're speaking about today is a patient who's been diagnosed with localized prostate cancer. We have risk stratified them, and the majority of them will be low risk. Some of them will be intermediate risk. And these are patients who do have management options. They have, 3 good options. I think, in fact, when I have all our newly diagnosed localized cancer patients, I tell them they have 3 good options. They can either do nothing beyond a period of surveillance, have surgery, or have some form of radiotherapy. And I think, therefore, within those 3 things, it depends on that risk stratification about which of those options we are more likely to recommend. So clearly, the low-risk patient, we're very likely to very strongly recommend active surveillance. But it's also important that we make patients aware that they have management options. And here's where, of course, it gets confusing and sometimes distressing for patients. They experience distress and anxiety due to the fact, well, I've got cancer and I don't know what to do, doctor or nurse. And how do we tackle that? How do you tackle that when so-and-so comes back for their diagnosis, or they've met the specialist or the reg to hear about the biopsy, and they've been told, yes, it's cancer, but he or she has given me a few options. So it's a very interesting area, the area of decisional conflict or anxiety due to management concerns. How am I going to make my mind up? Whereas a patient with an obstructing bowel cancer coming into the emergency department, there's only one option. It's very easy. We're going to go to the operating theatre and fix you. So these ones where patients have options can be very, very stressful for them to deal with. And that's a really, really important theme for us in active surveillance, is to make sure that of those patients, especially who look like great, safe candidates for surveillance, that we do our best to make sure they're very confident in that decision, that they don't experience anxiety, and that they don't, for example, decide to have surgery just because of their anxiety or decide to have radiation. And that's what happens in many, many other jurisdictions and countries. That's why in the US, active surveillance utilization is still way behind the rest of the world. I think there's an over-treatment culture in some centers in the US that means that's what happens. Or they'll say, oh, the patient was anxious. That's because you made them anxious, and so on. So that's just a few themes that we should explore. But yes, by and large, of these other two great options that people have for their localized prostate cancer, especially, of course, for the unfavorable intermediate risk and high risks, this becomes another thing, which is that which should I go for, surgery or radiotherapy? And I think we can summarize with a few points here. Number one, multidisciplinary care is best. Absolutely. If you've got multiple options, you should be getting the advice of multiple different experts in those areas so that you can make a decision you feel confident about. Another theme, of course, is getting a second opinion. Because of that, offer patients a second opinion. The majority of our patients at Peter Mac and in cancer specialists are all second opinions, but even the ones we diagnose ourselves, we'll say to them, you should go and get a second opinion. This is not an emergency. It's more important that you feel well informed and make a decision you feel confident in, rather than rushing into surgery, especially because normally these patients are diagnosed by surgeons like me. So we're very, very keen to offer multidisciplinary opinions. Even if patients are gunning, they've come in for a second opinion, they want a robot prostatectomy done by us, we'll still make sure they feel well informed about radiotherapy as an option for those patients. So I think that's just a good culture, and patients tend to know this largely from speaking to folk like you, or being in PCFA support groups, or just reading widely about prostate cancer on the internet. They'll figure this out and they will come for second opinions, but some don't. So they're the ones I think we should do our best to inform them. Yes, and whether you go for surgery or some form of radiotherapy, you'll all be aware that high volume centers, high volume surgeons will deliver the best outcomes. And so therefore, it's not about whether, this is what I say to patients, it's not about whether you have a robotic prostatectomy or an open prostatectomy or a laparoscopic prostatectomy. It's about making sure that whoever is doing your surgery is a high volume surgeon who's very well trained in this operation, and he or she does a large amount of them, because those statements I've just made turn into best outcomes for your patients. Yes, and of course, many of the highest volume surgeons around the place tend to be have access to a robot or offer robotic surgery, but there are plenty of low volume surgeons out there as well. And the classic tale for me is someone who comes in from a high volume open surgeon, who I know is a high volume surgeon, does a lot of these operations very well, highly trained. And then the patient will come for a second opinion about robotic surgery. And I'll make it very clear to them that the key outcomes, the continence, the cancer, the erections, are going to be the same if you're operating on a high volume open surgeon or a high volume robot surgeon. Yes, you might get out of hospital a bit quicker and so on, but that's an important message. And for example, if you're being offered surgery by a high volume open surgeon and you've gone to a second opinion from a low volume robot surgeon who does a bit of everything, well, you're going to be better off with the high volume open surgeon, aren't you? So volume trumps everything is my message to you. And multidisciplinary care, we're very keen on that, as you know. We've written a lot about multidisciplinary care. Here's our multidisciplinary meeting at Peter Mac, where I was this morning. Of course, the room's not so full anymore. It's a hybrid meeting. And we wrote about, in particular, how we embed the nuclear medicine team because of our big interest in PSMA imaging and theranostics. But I still think that's important, whether it's a big kind of traditional multidisciplinary cancer meeting like we run, or a kind of a virtual one in the rooms or wherever it might be. The key theme is the same: multidisciplinary care trumps all. This is interesting, just finishing up, how do we support patients when they're stressed and wondered about, is surveillance the right thing for me? There was this great study running called Navigate, which is now fully recruited, so it's closed, about 300 patients. And this is awaiting publication. This is a lovely study of a randomized trial of a decision aid. So half the patients got the resource from PCFA to read about, the excellent resource online and with the printed leaflets. And the other half got this website that we built called the Navigate website. Very nice, rich website full of videos by patients and specialists and so on. And people can click through it and identify what is valuable for them. So it's a decision aid. And decision aids are very important when you have multiple options. And hoping that this trial shows that the online decision aid adds value and helps people feel more confident and less anxious, then great, you can flick the switch and run something like that out across the whole country for patients, regardless of where they are. And some of you have been involved in developing that content. And also, of course, reaching out to PCFA support groups and PCFA nurses for these newly diagnosed men who are anxious is really, really important. And the worst thing in the world that can happen is the anxious patient, newly diagnosed, low-risk cancer, makes a decision to have treatment. That's a failure of counseling and making sure patients feel well supported. So we push them out, not to navigate anymore, we can't do that, but to PCFA support groups, PCFA nurses, and other resources out there, because you guys and girls are often, really the reassuring touch point. You've often met the patients early on. Some of you have met them before biopsy even, so you build a rapport. They prefer you rather than us, who give them not enough time. So you play a very, very important role in ensuring these patients feel very comfortable. And finally, I just want to show you this from this morning. So the VCR, the Victorian Cancer Registry, today, you'll see this in the paper, we just tweeted out about it, released their annual report. And this is the Victorian Cancer Registry data from 2020. So it's the first registry, it's the most up-to-date registry in Australia. So it's the first one to show the impact of COVID from last year. So this is the complete data from 2020. And what it showed overall was about a 7% decline in all cancers. But look at this, the standout problem is with prostate cancer, a 13% decline over the whole year in prostate cancer diagnoses. So what that means is more than 800 men in Victoria who we expected would be diagnosed last year who were not diagnosed, about 900 out there missing. And we think it's the same this year. We haven't really seen a recovery. So I think the 2021 data will continue. So that, we estimate there'll be 1,500 men or more in Victoria. Victoria being worse than the rest because of the prolonged lockdowns, who are out there not yet diagnosed. And interestingly, within this, the decline, we see that, yes, there's an 18% decline in intermediate cancer, 8% decline in those with advanced disease who will still turn up symptomatic this year. So big data, it means we're all going to be very, very busy in the next year or two across the health services, catching up with these poor men as they hopefully come in. So there are my final messages to you. I think we here in Australia do utilize active surveillance very well with very good outcomes. But we can tighten up our surveillance to make sure that we don't drop the ball for some of these guys. Also, in the decision about having active surveillance, and patients should be well informed about other options, make sure that they feel comfortable about getting a multidisciplinary opinion and use decision aids and support groups to help them feel confident how they go forward. And yes, I'm sorry to say that COVID is going to have an impact on us. We love podcasting about GU cancers, prostate cancer especially. Any of you who are interested in podcasts, search us out. I know some of you listen to us because you've sent us messages. And Chris, we must do one on the role of the PCFA nurses at some stage. We've an interest in doing one on regional nurses, especially actually to support those patients best. But you can find us by searching GU Cast anywhere. And we did do one with the Navigate team and had Alan White, one of our patients, in to talk about this. So this is a really good episode about managing men on active surveillance. And then a couple of weeks ago, we did one on this ridiculous change to the NCCN guideline in the US, where active surveillance was declared as the preferred option for low-risk cancer for the past few years. And in their update, they dropped preferred. They literally put a red line through it, which caused consternation because it looked like a negative recommendation. So we did a very good podcast on that with Matt Cooper-Berg, one of our good mates in the US. And I was pleased to see last week that they reversed their dropping of preferred due to social media pressure on Twitter and our podcast as well. With that, I'm going to stop and hand back over to you, Chris.
Excellent. Thank you so much, Declan. It was a really good podcast. I did listen to the one that you did about it the other day, which was really good and good outcomes. Obviously, circumstances have changed and COVID's really presented some challenges, but some real great opportunities. And it's good that people are listening through those channels as well, not just from consumer perspective, but political channels as well and membership. So that's really great to hear. So we've got a couple of questions coming through. I'll bring Ian back in here as well. Jeez. Let's just change this to a gallery view for everybody. So we're just going to have a couple of questions and talk a little bit more about some of the things you touched on in that presentation, Declan. And I think one of the kind of things that comes out of a lot of inquiries to us is what is the difference really, Declan, between watchful waiting and active surveillance?
Yeah, good question. So there's a nice paper in Lancet Oncology a few years ago from Chris Parker that summarizes this, but I like to summarize it very simply as saying, if we have a patient who we're considering conservative management, because that's both of those options, but if his cancer changed in the future, we would consider him for curative intent treatment with radiation or surgery, then that is active surveillance. And that tends to mean you're having repeat biopsies. In other words, you're watching for those changes that you'll only see on a biopsy or plus an MRI scan, so that if the cancer changes, you would consider offering radiation or surgery. So that therefore tends to be younger, fitter patients, doesn't it? Whereas watchful waiting is a strategy based not around intervening with curative intent treatment. You've diagnosed your patients and you're watching them, but really the only thing you're going to do in the future is put them on androgen deprivation therapy to slow up progression to metastatic disease. So that tends to be the older patient with comorbidities and so on, that, you know, there's no point subjecting him to repeat MRIs and biopsies, because you're never going to do surgery or local radiotherapy. And so clearly some patients will go from active surveillance, they get older, into their mid 70s is about it for me, mid to late 70s. Cancer hasn't changed in 8 years. They're now on watchful waiting, and they've already shown they're not going to change very quickly. So we tend to de-escalate, avoid MRI and avoid biopsies.
Another element, I guess, you touched on earlier was that the urologist is obviously the key clinician in a man's prostate cancer journey, and alongside that, obviously, the man's GP. Talking about this care outside of the hospital setting, especially within the active surveillance realm, what other members of the MDT are important for a man that's been diagnosed with low-level disease that's looking at active surveillance as a monitoring method?
Well, for sure, at diagnosis, I think the support of a nurse, if you can get access to a PCFA nurse or a prostate cancer specialized nurse outside PCFA, then they are key stakeholders in supporting those patients and answering questions for them and helping them on the journey. So I think there's clearly a role there at the start. We don't tend to refer out to radiation oncologists necessarily if it clearly looks like an active surveillance patient. We don't want to bamboozle them with that. We'll talk general terms about intervention versus surveillance, but if we're really steering towards surveillance and we feel confident, it tends to be just within our team and the nurses looking after them. And then likewise, when you're on surveillance, once you've made that decision and you're on surveillance, and nurse-led protocols can be very helpful. And that's what we do at Peter Mac. These patients are in a nurse-led clinic following a protocol. So that means for us, PSA is 6 monthly, and then an MRI and a biopsy within 12 to 18 months. And they normally come back into a clinician clinic just for that period, just to, you know, make that decision about the repeat biopsy and so on. So there's really an opportunity to share care, because these tend to be protocolized follow-up for these patients. So ideal really for a nurse-led setup.
You hit the nail on the head. The landscape's changed dramatically in the last few years, and the introduction of specialist nurses, including the PCFA prostate cancer specialist nurses back in 2012. So, Ian, being one of the first nurses that sort of came onto the scene, you've seen a lot change in the landscape. Exactly what Declan's talking about now, making sort of pathways a little bit more clearer, defined, and supported. Would you be able to speak to what the role of a prostate cancer specialist nurse is?
Definitely, Chris. And thanks, Declan. I really enjoyed that talk. We'll certainly have to look at our transrectal probes in Hobart and get rid of them. The role itself can be quite varied, and probably no two specialised nurses around the country do exactly the same thing. It really depends on what hospital you're in, services, and what was offered at the time you come on board. We have sort of time. The PCFA has told us to just examine the hospital that we're going to, find out where the gaps are in service, and help maybe fill that. We're there to complement that hospital, not take over anything. We're very much about psychosocial support, and there to provide reliable information about treatment options and side effects. And some men, we all know, like to do their own research and find some quite dodgy things on the internet. We're there just to steer them in the right direction, answer any questions, help navigate the whole journey and the whole treatment pathway, help maybe with any test scans, how sometimes they have never been in the hospital system, so just help them with how the whole medical hospital system works. We're sort of an open point of contact. We're there. Some guys will ring a lot and their family, and some never ring, and it's very important to follow up with those guys that don't ring as well. And you can be a bit of a traffic cop, I suppose. You link them in with other services, hospital and community, continence nurse, physios, exercise, physiologists, a big one at the moment, social work, basically anything, and link in with all the support groups around. I mean, I suppose getting a new diagnosis or getting new treatment regimes is a very stressful time. And although urologists, etc., explain it very carefully and clearly at the time, sometimes only take in about 20% or something. So usually a good follow-up phone call or take them aside and just make sure they can, they've understood what was said to them is very important. And just not being rushed in the process. I think that's where we come in quite a big way. And just give them plenty of time to talk, get things off their chest. Usually at diagnosis, I try not to bombard them with too much stuff. I'd like to give them a booklet here and there, and give them my contact details and just let them contact me as well if they need to. Often there was a lot of questions they wish they'd asked, but we just give them time to ask them and help them with these as they come up. Really, yeah.
Yeah, thanks for that. It's a supportive role that was very well needed, I guess, in that spike of the early 2000s, where we were doing a lot more sort of treatments surrounding prostate cancer, and now we don't know how we can live without them in the system. So making some really great change with supportive care pathways, as well as being the advocate for the patient and being that breakdown of information and connection to the health industry. So really, really great work of the actual role of the prostate cancer specialist nurse. I guess one of the hardest things is copying a diagnosis of cancer and then prostate cancer. So being told you've got prostate cancer, but then being told you can wait is always one of those questions, or one of those hard processing points for a man to be told to wait on something where our psyche operates a little bit differently. So I guess could you speak to the initial sort of shock around the diagnoses of prostate cancer and your role as a nurse and what referral to services might be appropriate at that stage?
Okay. Yeah, thanks, Chris. Well, I certainly don't go through a wide range of emotions, although with the use of MRI now, men have sometimes quite a good idea that they're going to get prostate cancer even before their biopsy, which sometimes lessens the impact, but for a few, it can actually just cause it to increase their stress levels and just cause it to be dragging out a little bit. I introduce myself if the MRI suggests a bit of prostate cancer. And the more meetings you get early on, the more rapport you build with the patient and the family. So I always do that. I like to adjust my strategy for each patient, depending on their level of understanding, etc. I suppose, sometimes men come back having talked to people or support groups after the diagnosis, and they have a fixed idea in their mind about what treatment they'd like, and it's usually hardly ever active surveillance, to be fair. In fact, when they read the booklets, etc., they focus on the two other things, the radiation and the surgery. And when we introduce active surveillance to them, most are very relieved at this thought, but every now and again you get someone that finds it really hard to comprehend. And I suppose there's a lot of people, I mean, we think of the media they really reward people for fighting cancer and doing this, and they find it hard to get their head around active surveillance. And so then we just slowly introduce it, bring them back in a few weeks, tell them there's no rush for this, and hopefully over time they'll come around to the idea that it's certainly best for them. And I suppose I really like at the moment the standalone booklet, which PCFA is produced. Before this year, there you go. Before this year, I really struggled. There was a couple of things from the Cancer Council I used to hand out with, a couple of paragraphs, etc. But I think a standalone booklet which tells them this is the structure, etc., is a really good. It's not just good for them. Sometimes the urologists look at it and say, "Oh, well, yes, okay, we're doing this, 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 and this." And junior doctors as well, they can follow a nice protocol and just make sure we're following all that. So it just gives them something to bounce back off, because they go out with their mates and they say, "You've got cancer, you're not doing anything about it." And they go, "No, I am doing something about it, and this is what we've got." So reliable information is very important. Just trying to reduce their anxiety as they come back. I think with active surveillance, as they come back for each test, they get usually less and less anxious about the PSA, and just trying to be someone to listen to their issues, etc.
One of the great things that you've touched on there is that alongside a diagnosis of prostate cancer, regardless of an element of anxiety and some form of depression in that initial stage, and that could be ongoing if there is no supportive services, I guess, aligned to them throughout. So in that initial stage, it's always, I guess, a really great point to, and Declan, you probably speak to this, is have those conversations with your members of your treating team, right from your GP through urologists and your nurses that are within the facility, to be able to see what access to services there are. We've got GP management plans that we can access for mental health and allied health programs. So there's always a few elements there that we can sort of tap into in those stages to be able to get, it's a lot of information, it's a lot of stress that happens at that point. So it's a really great idea to have those conversations early and be able to get a bit of a plan together about some of those services that might aid these guys within this particular journey. A couple of questions that came through, Declan. We were talking about high and low volume centres and the correlation between sort of protocols and things like that. What would you classify as a high volume centre, and what would you classify as a low volume centre?
Thanks, Chris. Yes, I was going to type a response to Cindy. Good question, because patients will ask you this. They'll ask us this question. They'll say, I'm sorry to ask this question, but do you mind me asking how many of these per year do you do? So a bunch of studies have looked at high volume, low volume. What does it mean? What's the number? There is some disagreement, but my usual answer to this is if an individual surgeon does more than 50 radical prostatectomies per year, I consider that to be high volume. That's good volume. That means doing more than one a week during whatever weeks he or she is working. So I think 50 is a good number, anywhere in around 50. Full-time prostate cancer surgeons like me will do usually more than 175 per year, above 150 certainly. And that really means you are almost full-time prostate cancer surgeon doing that volume per year. And the concerns are, in the US, for example, it's been shown that, although there are these uber high volume surgeons that you'll all read about and so on, doing 150, 200, 400 of these a year, Vip Patel, maybe 500, 600 a year, the median number of cases done by urologists in the US is 4. So there are incredibly low volume surgeons out there in community practice in the US. And, in Australia, there's definitely a trend in towards higher volume surgeons, but lots of surgeons do maybe 10 a year or so on. And, I think doing 10 of these a year is very low volume, I think. And the volume outcome relationship has been shown to change by quartiles, the highest quartile, the highest 2 quartiles, etc. And I think about 50 a year means you do a lot of these operations and you're really generated a lot of experience over time. And to give you some idea, we published a paper in the BJUI a few years ago looking at the cost effectiveness of robotic surgery in the public system in Victoria. Marnie Bastow, my PhD at the time, who's a fantastic young urologist, did her PhD on this topic. And within that, we were comparing the costs at Peter Mac, being the only public centre at that time in Victoria versus other public hospitals. And we got data from the Department of Health in Victoria. And interestingly, you know, only 2 public hospitals in all of Victoria were doing more than 50 per year, the whole hospital per year, ourselves and one other site. And we now have better data on that right up to last year, showing that only 3 centres in Victoria, 3 public hospitals, do more than 50 per year in the whole hospital. And you know, Peter Mac does about 180, 190 per year. So we're obviously very, very high volume. And what we showed is I think 50% of hospitals were doing less than 10 per year in the public. Now that's not good volume. And that goes up to the other question Dennis Green was asking about the public system. How do you know what's high volume? Who's doing your surgery? Are they high volume? But I can tell you that in the public system in Victoria, a very large number of hospitals are very low volume, doing less than 10 per year. So, you know, for me, that's the vista of a busy public hospital, you know, no robotic experience, and the registrar and the fellow are, you know, doing very occasional prostatectomies, 1 per month or less, you know, and that's not high volume. And we know that doesn't equal good results for patients. In that topic, you know, of hospitals within the public as well, Dennis, is, you know, in Australia, you don't have a choice. That's the difference in public and private about which surgeon does your surgery in the public hospital. And in fact, oftentimes you can't pick which public hospital you go to. The funding of public hospitals tends to be regional. It tends to be the one in your neighborhood. You know, that's they've got a budget to look after patients in your region. Places like Peter Mac, it's a public hospital, but we take patients from everywhere, all over the country actually. But 90% of ours are Victorian, so patients can be diagnosed anywhere. And if they want, they can come into Peter Mac and have robotic surgery done by a very high volume team. But there are 5 consultants at Peter Mac, and they don't get to pick which consultant, but at least they know they're going to be operated on by a high volume team. Yep, there's going to be senior fellows doing steps of the procedure. And the other thing about that, which does help other public hospitals, is like the 5 urologists who work at Peter Mac also work in the private, where volume's much higher. So you have very, very high volume clinicians. And that can be true in some other public hospitals, even though that public hospital might only do 10 or 12 per year. It may well be that, you know, some of the surgeons working as VMOs in those hospitals are also doing 2 or 3 a week, or 1 or 2 a week in the private. So at least they may be high volume and they're bringing that experience in, but they're still obliged to train the registrar or fellow. So look, you might expect this from me, and if I had some of my other hospital colleagues on the line, they'd be saying, "Come on, Declan, you're just trying to pull all the work into Peter Mac and places like that." But it is still true to say that higher volume centres, this is well published, as well as higher volume surgeons have better outcomes, and so that's still very important to try and identify this and try and grow volumes. And without, you know, I know I'm taking up all the time, Chris, but in some settings, like in the UK, for example, they've created high volume centres. They started doing it with esophagectomy and then cystectomy for bladder cancer, once it was very clear that high volume outcomes had better results for patients. And by default, they've almost done it with prostate cancer, because in the UK, you're only allowed to have a robot in your centre if you do more than 50 cases per year. The NHS will not fund you if you do 49 cases. So chief execs, you know, balk at this. So what happened when that happened was suddenly high volume centres were popping up. Places like Guy's, where I train now, have 6 robots, and they suck in the work from everywhere. And for them, the money comes with the patient. So it's kind of a semi-private model. The more work they do, the more reimbursement they get. Whereas in Australia, the more work we do, the more we lose, actually, because we're given a budget by the Victorian government. Where, you know, we don't suck money in from Canberra and Tasmania, but we still look after everybody because Peter Mac has that sort of philosophy. So that's just a few thoughts about it. You know, you won't be surprised to hear that, you know, higher volume centres will have better outcomes, but it's not always easy for patients in the public system to get access to higher volume centres without having to travel or and so on.
I guess I'd like to talk about the cost associated to a man on active surveillance. So going through MRIs and biopsies, and you just sort of touched on it there about that public and private perspective, having MRIs and PSA tests and scans and biopsies and all sorts of things over the period of time that a man's on active surveillance, does it become costly? Is there costs associated? Can you speak to the private perspective and then for the public perspective for somebody that's on active surveillance?
Well, I'll say to you, first of all, that in the US a few years ago, when they were trying to encourage active surveillance to increase, people like Matt Cooperberg, they did a study showing that if you're a surgeon managing your localized prostate cancer patients, you make more money out of having your patient on surveillance over 3 years. So they were using this as an incentive to the American market, saying, don't worry, the fact that you're not doing a prostatectomy on that guy next week means that if you keep him on surveillance, don't worry with all the visits and so on. But that's just the vagaries of the US system. But here, like all this stuff is funded. So repeat PSA tests are all funded. If you've got a prostate cancer diagnosis, you're not paying for any PSA tests, even if they're being done every month. Likewise, MRI now totally reimbursed for active surveillance patients. There are a few criteria. You're not supposed to have one more than every 3 years or so, unless you have clinical concerns. So we can always write, DRE abnormal, and then they get the MRI reimbursed. And likewise, if you're in the public system, of course, you don't pay for anything. So if you're being booked for a prostate biopsy, that's all covered. If you're in the private system, of course, for procedures like a biopsy, you're still at the mercy of your health fund and whatever gap your surgeon might be charging. And look, that's the same across the whole system. And messages we always have about that are, again, get a second opinion. I mean, this whole topic of financial toxicity and financial distress is one we've written about in the newspapers. And people should always feel comfortable if they're in whichever system, especially the private system, and they're feeling under pressure and they can't afford gaps. The public system looks after cancer very, very well, by and large. All public hospitals can offer prostate biopsies and so on. And most of them are now going to be offering transperineal biopsy. So I think always understand that if you're under financial pressure, the public system, especially for cancer, I always say to patients, cancer, trauma, children's, and brain tumors, the public does really, really well on that. Not so good for your hip replacement or your hernia or your tonsils. You're going to be waiting years. But by and large, cancer does get quite prioritized. And if you're prepared to go to the fancy cancer centers, they tend to, because we don't have emergency departments, we don't have elective other surgery, we just look after cancer. So, the wait times tend to be manageable.
One thing that I saw a fair bit, I guess, in practice at a high volume centre was that there were some guys that came through with, sort of low, what was suspected to be low volume disease, but higher volume on, say, MRI and other aspects that would normally have fit into active surveillance, but really was that next step into having to have treatment because it was a lot more aggressive disease. Is there any, and showing a little bit of a genetic factor there, is there any studies going on that you're aware of recently looking at the sort of man that's classified as an active surveillance Gleason 6, but he's actually got more higher volume disease there that needs active treatment?
Yeah, so look, it's a great question because the nihilists out there will criticize active surveillance by saying, well, when you do operate on these patients a year or two later, the ones that need surgery, you have higher risks of extracapsular extension and so on. And this is really not well supported by data, because every single patient we operate on, based on the biopsy to the final prostatectomy, has about a 20 to 25% up voluming. So we're always trying to factor that in. When you have the whole specimen to look at, in 25% of cases, there's a bit more there, or it's slightly higher grade. That's already, burnt into our assessment of the biopsy findings in front of us. And that's where I think the point we were making about widespread use of MRI pre-biopsy, then targeted biopsies, transperineal, means that we select patients very well. So the likelihood of what you've just mentioned is very low, not zero. Hence, surveillance is important. Good surveillance is important. In the US, there's very little use of MRI at all pre-biopsy because it's not funded. There's very, very little use of transperineal biopsy. It's all transrectal. So you tend to have a less, we would believe, a less accurate sampling of an individual patient to make sure they're suitable for surveillance. And they tend to prop up that kind of, poor 20-year-old diagnostic paradigm by doing genomic testing on the samples and bang on about these things that are funded, Decipher and these types of Polaris testing. But it's much better in the first case to do an MRI and do a proper biopsy. And then I think we do select patients very safely and with high confidence that they're not going to have significant disease that we haven't fully appreciated.
Perfect. So I guess we're coming to time now, but one last sort of question posed for comment from both of you, I guess, in regards to resources. And Ian, you touched on this before, but resources for somebody that's looking at active surveillance. Where do they access something appropriate for this particular monitoring method? And I'll start with you, Ian, from a resource point of view.
From a resource point, well, you can contact your local specialist nurse, and even if you're not quite in that area, I'm sure somewhere close by, you can get all the details of where we all are on the PCFA website, or you can contact the telenursing service, who should be able to provide you with some information on it as well. Yeah. Yes, and the active surveillance. They will provide you with the active surveillance prostate cancer booklet, which I really like. I think, yeah, it's very good. I'm backdating a lot of them now, like a lot of patients that I've seen for like 5 years, and now I hand this out to them, and they've been on active surveillance for 5 years. They actually really appreciate it, because I think we've always given them out books with a lot of other stuff in them, and they don't really read all that. They look at what may happen in the future, and they'll read about the surgery, etc., but they don't look at what they're actually on now. And this book is a nice standalone book just to sort of sit there at home and just refer to it every now and again. And it just backs up what the doctors are saying to them.
Perfect. Yeah. Declan, any resources for the man that's on active surveillance that you can think of?
That's what we recommend as well, Chris. But I think encouraging patients to reach out, get a second opinion, don't panic, don't rush. And nowadays it's so easy to get second opinions on telehealth as well. There should be no barriers. And as I hinted at earlier, when we see patients that they've had a radical prostatectomy or radiation, and they've come back often with issues and they're not happy, they've come for a second opinion, you look and say they should never have had treatment. And often then it's a failure of us counseling patients correctly at the start. So, if you get it right at the start, you're going to save those patients from treatment. And I think if you have very anxious patients, a psychologist can also be a good thing. The Navigate study was led by our psychologists, and we don't routinely refer to psychology, but for the uber anxious patient who, just can't sleep at night, he's coming in saying, I can't work, I can't do anything. Then going to that next level of getting more professional support. And there are some specialized prostate cancer psychologists around the place for those patients that you feel, they're just going to make a decision to go for treatment because they can't cope with anxiety. Guess what? You need to treat the anxiety, not treat the prostate cancer. It's a failure of our support for the patient if too many of those patients have treatment. Understanding some patients will still just not accept matters and just need to have high quality treatment if they are going to really push for treatment.
Exactly, yeah. Thanks, Declan. So I'd like to thank everybody for joining us today for this educational webinar on active surveillance for prostate cancer. There was some really great information, good discussion there, and I hope that you've managed to learn something valuable for your own journey or for the men that you're caring for that are under active surveillance. So you will be able to view a recording of this webinar on the online community and the PCFA channel in the coming days, and a link will be sent out post the webinar in the next 24 hours with that link as well. You can access the active surveillance booklet that we just showed on screen before via the PCFA website, and there's a new suite of resources there, a lot more broken down through the individual pathways, and that being of active surveillance is available on the PCFA website under the resources tab. You can find more information about the prostate cancer specialist nurse service as well on the PCFA website, and you can also contact if you don't have a prostate cancer specialist nurse within your area, you can contact our telenursing service and be able to talk through where you're at your journey with one of the nurses online. And as Declan said, if you haven't already, subscribe to the GU podcast. It's got some fantastic information about prostate cancer and GU stuff on it. So I do recommend flicking back through and listening to a few of the episodes there. So again, thank you, Declan, thank you, Ian, and thank you everybody for joining for today. I hope that it's been a well worth webinar as per the feedback. People are loving it, so that's good. I'd like to thank you, and until next time, goodbye.
Thank you.
And Merry Christmas.
Yeah. Thank you.
Thanks so much. Thank you.
Thank you.
Cheers.